Thank you very much. These are my disclosures. And I do have some additional disclosures as well. Despite being a surgeon, I am an endovascular enthusiast. Some people would call me an endovascular cowboy sometimes. I've been performing carotid stenting actually for over 12 years, and for the same time period been doing endarterectomy as well, and I actually enjoy performing both. So my challenge here, my charge, is to tell you that carotid endarterectomy remains the gold standard for treatment of asymptomatic carotid artery stenoses. It's a beautiful operation, and there's no question that it's been proven safe and effective treatment for prevention of strokes in patients with carotid stenosis. The issue is that most of the non-surgeons kind of view the procedure like this, and therefore the enthusiasm for carotid stenting as an alternative. But that being said, in terms of carotid endarterectomy, it is a single surgical procedure with the most level 1 evidence backing it as being effective, and in the case of carotid disease, both for symptomatic and asymptomatic disease. In terms of asymptomatic carotid stenosis, there have been trials, randomized controlled trials versus best medical treatment. These are a little bit dated now in terms of contemporary best medical therapy, but of course everybody is familiar with ACAS and the ACST trials that show the unequivocal benefit of endarterectomy in patients with asymptomatic carotid stenosis in excess of 60% luminal narrowing. And compared with best medical therapy in those trials, there's a 50% event rate reduction in terms of ipsilateral stroke and death. And if you look at meta-analyses of these as well, and forest plot analyses, specifically looking at the risk of ipsilateral stroke in the first 30 days, in the randomized controlled trials, there's clearly been shown to favor CEA versus medical therapy at the time the trials were performed. Now, the only randomized controlled trials that we have for treatment of asymptomatic carotid stenosis with carotid artery stenting are really the CREST and the SAPPHIRE trials. SAPPHIRE is a little different since it was a high surgical risk cohort that was in that trial and with some more dated technology. But certainly in terms of CREST, comparing the two in terms of reduction or avoidance of ipsilateral stroke, it did favor CEA. That being said, it was a composite endpoint that was the primary endpoint in the trial, looking at stroke, death, and MI. And with that composite endpoint, there was no difference at the 4-year, 30-day, or 4-year endpoint. 6.8% for the composite endpoint for endarterectomy and 7.2% for stenting. If you look at the periprocedural outcomes in CREST, you can see that the incidence of stroke was lower with endarterectomy than with stenting. Most of these were minor strokes in the stenting group, not major strokes. No real difference in death, but that there was an increased incidence of periprocedural myocardial infarction in the endarterectomy as opposed to the carotid stenting group. If you look specifically at asymptomatic patients, since CREST contained a combination of both symptomatic and asymptomatic patients, the asymptomatic cohort had a little more than 1,100 patients that were in it. And if you look here at some of these outcomes in terms of all strokes, the incidence of stroke in this asymptomatic cohort was about twice that of endarterectomy in the stenting group, but that didn't reach statistical significance because of the smaller sample size. Most of those were minor strokes, which was true in CREST as a whole. Now, probably the speaker, Dr. Collins, who's going to follow me, is going to point out and have a lot to say about periprocedural myocardial infarction, which kind of offset the increase in strokes with stenting and being significantly higher in the carotid endarterectomy group. Again, in the asymptomatic cohort, this doesn't reach statistical significance. And then looking at the composite endpoint, stroke, death, and MI, specifically in the asymptomatic group, again, no difference with basically a totally equal number of events, 21 in each group. Now, in terms of the issue and the outcome and the effect of periprocedural myocardial infarction, it's a relatively infrequent event in 1 to 2% of patients. It was about in twice as many patients in endarterectomy as opposed to stenting, and that was statistically significant in CREST as a whole, whereas it was not in the asymptomatic group. And if you did have a periprocedural MI, certainly there was an increased risk of both early and late mortality out to 4 years in CREST. So periprocedural MI is certainly not benign and may serve as a marker for poor late outcomes, usually due to cardiovascular problems. That being said, the effect of stroke shouldn't be minimized here. Even though these are minor strokes, any stroke within 30 days in CREST also had kind of an equal hazard ratio in terms of being predictive of poor outcomes, including mortality at 4 years. Now, this is a paper looking specifically at the issue of ipsilateral stroke following the procedures in CREST periprocedurally for the first 30 days. Most of the strokes that occurred with carotid artery stenting were early here. Carotid stenting is in the black bars versus endarterectomy in the white bars, but at each time point here, there still seemed to be more strokes in the stenting group as opposed to the endarterectomy group. If you look at the effect of an ipsilateral stroke on long-term mortality, it was a 21% mortality at 4 years attributed to ipsilateral strokes, and stroke itself was independently associated with nearly threefold increased mortality in those patients who experienced a stroke. So it's certainly not benign. Now, that being said, in addition to those clinically evident strokes, whether they were minor or major, there's also the issue of diffusion-weighted imaging lesions that show up on MRI. Following carotid procedures. They seem to be much more frequent after carotid artery stenting than with endarterectomy, looking usually here at single series or single institution reports. In the ICSS study, which looked at symptomatic patients specifically, there was a sub-study where they did diffusion-weighted MR on these patients as well. And in this prospective study, there was a significant increase in the finding or the incidence of these diffusion-weighted lesions on MRI after carotid artery stenting with distal embolic protection in 50% of the cases versus only 17% of the cases following endarterectomy, and that was highly statistically significant. Now, I think that outcomes of carotid stenting will be improved, specifically with regard to that ipsilateral stroke issue with the use of proximal protection, and that wasn't in those trials, specifically CREST, that I was talking about. This is the Michi system for flow reversal as well, that also is currently in the Roadster trial and may show some promise. But based on these study findings, the most recent set of guidelines from the multi-society group with regard to asymptomatic carotid artery stenosis say that it's reasonable to perform CEA or endarterectomy in asymptomatic patients who have a greater than 70% stenosis if the risk of perioperative stroke, MI, and death is low, so in good risk patients, and I think that that's important. It's reasonable to choose endarterectomy over stenting when revascularization is indicated in older patients, particularly when arterial anatomy is unfavorable for endovascular interventions like stenting. But it may be reasonable to choose stenting over endarterectomy when revascularization is indicated in patients with unfavorable neck anatomy or the hostile neck, the redo carotid, the radiated neck, that sort of thing. But that being said, I think these recommendations would indicate that endarterectomy remains the gold standard for asymptomatic carotid stenosis, except in patients with that unfavorable neck anatomy. Importantly, in the recommendations, they recognize that in patients at high risk of complications for carotid revascularization by either technique, endarterectomy or stenting, because of comorbidities, the effectiveness of revascularization versus best medical therapy alone is not well established, and maybe those patients should be treated medically as opposed to intervened upon. That's specifically the issue that's going to be addressed with several trials. This is the SPACE 2 trial that's being conducted in Germany, where they are including a conservative arm, which is actually is best medical therapy, including statin medications. That's also the aim of the CREST 2 trial that hopefully is going to be starting here in the United States as well, where in addition to carotid artery stenting and endarterectomy, there will be medical treatment arms as well. to try to establish whether or not intervention or best medical therapy is currently the best treatment for asymptomatic carotid artery stenosis. So in conclusion, I really think that this is a no-brainer. I think that endarterectomy has proved to be safe and effective for preventing strokes in patients with asymptomatic carotid stenosis and still remains the gold standard today. While limited randomized controlled trial data has shown that stenting is not inferior to endarterectomy in experienced hands, the periprocedural stroke risk remains higher with stenting than with endarterectomy. Use of proximal protection may improve those results, but that has yet to be borne out in randomized controlled trials. Stenting may be preferred, and that's where I predominantly use it in the treatment of patients with unfavorable neck anatomy. And the bigger question, I think, specifically in dealing with asymptomatic disease is the role of any intervention versus best medical therapy, or the combination, which is better when you're treating asymptomatic carotid artery stenosis. Thank you very much.